Okay, good morning, Brett. How are you today?
Hey, Sean, I'm doing well. How are
Can you
you?
hear me? Hey, I'm doing great. Good to see you. It's awesome. So I look forward to talking to you. You're one of my favorite people, cardiology folks to talk to. But anyway,
Well,
I'm
thanks.
very
I
excited.
appreciate
So,
that.
are you in San Diego or are you located today?
Yeah, I'm in San Diego. Not
Okay,
far from you, right? You're just up the coast a little?
I'm in Laguna Beach today. So
Very nice.
we're actually renting a house here for a couple months while we renovate our other home. So it's to get ready to sell to move out of state for better or for worse. So.
Oh, okay.
We're going to be up in the Pacific Northwest for the next few years anyway. So it's just a work decision that my better half has to do. So
Yeah.
anyway, so are you? Let me ask you because I know you've gotten heavily involved with the diet doctor stuff. You've been there for quite a few years. Is that full time now? Or are you still doing your cardiology practice?
Yeah, I'm doing both still. So my,
Okay,
my main work is with Diet Doctor, but now I have my own preventive cardiology telemedicine practice. So still seeing patients. I never want to give that up. I love working with people one on one and helping people one on one. Although through Diet Doctor, I can reach millions of people, and then with my own practice, I can get a little more detailed one on one with people. So yeah, I'm really enjoying that still.
very good. Well, I guess obviously your expertise is cardiology, but I mean, I'm sure you did an internal medicine residency before you did the cardiology specialty. So you've got a broad background. It's one of the things that, me as an orthopedist, I mean, I'm doing stuff that I never really was sort of involved in, talking to people about diabetes and, all this other stuff that wasn't really my main purview, but you learn all that stuff. And I'm sure, particularly with regard to nutrition, and nutritional research and a lot of the stuff. I mean, because as I see you kind of new study comes out and you're the guy that interprets it for the
Mhm.
the diet doctor crowd, and so you're kind of probably branching out in a lot of areas where you probably didn't before.
Yeah.
Um,
Yeah, but
Let me ask. Go ahead.
just to comment on that though, like you said, you're an orthopedic surgeon commenting on nutrition, which is not what you're trained in. But what field of medicine is trained in nutrition?
Right, sure.
Really, like really none. So I went and got special training in behavioral medicine and functional medicine and in nutrition certification and even personal training because we don't learn that stuff in medicine. So it really is up to us to teach ourselves. And one of the things that bothers me is if someone would look down at an orthopedic surgeon and say, what is he doing? He's just a surgeon. He shouldn't be managing nutrition. Well, like what internists are good at managing nutrition? I just don't see that as being a good argument at all.
Well, I mean, to be fair, I mean, and I'm sure you're familiar. We've seen very many people that come from all different backgrounds that are very smart people that can learn and read and study
Yeah,
literature
yeah,
and observe things around them and make decisions. And I think that's sometimes the beauty of not having almost, I always kid around saying my medical training was almost a hamper, a hindrance, because you've kind of been taught a certain way, which might have been wrong. And so it's kind of like,
yeah,
despite of the fact that we're physicians, we figured out, how to maybe deal with nutrition. That's arguable. Some people would disagree. And there's people with, nutrition science PhDs would say, you guys are clueless and don't know anything. And yet at the end of the day, we're actually seeing the consequences as clinicians every day of this stuff. Whereas the nutrition PhD, they have almost no clinical experience. And so
right.
at the end of the day, it's where the rubber meets the road, really, I think.
Yeah, that's a great point about our training almost being a negative. I mean, my preventive cardiology fellowship was in an Ornish style program. It was very low fat, very plant based, and vegan type diet. And so I was trained that that's the way everybody's supposed to eat to improve their cardiovascular health and improve their health. And it took me a number of years to undo that. So yeah, I think your point is well taken. Although I think the experience was good for me to have to show that it's not as, clean cut and certainly as easier and enjoyable as a lot of people make it out to be. But that training led me down one road as being the truth, as being the one way that everybody's supposed to eat. And I had to undo that myself because training didn't do that. So yeah, you're absolutely right about that.
Yeah, and I think also, we both agree that eating is one part of the puzzle. But there's a lot of other things going there. I think exercise and so many
Yep.
other sleep and all these other things, stress management also play a huge role in all this stuff. Um, I would be seriously, and I know you talk about this all the time, and I've talked to you about it before, but I would be seriously doing a disservice if we didn't at least touch on blood lipids and cholesterol and heart disease. But I want to get your take. There was a recent analysis, the Women's Health Study data, and looking at relative risk for certain factors, diabetes by far. I mean, this
Yeah.
almost an order of magnitude was like diabetes is the driver of cardiovascular disease, at least in that cohort population, which was not a small population. And then in that, obesity was in there, and some of the inflammatory markers, and LDL cholesterol was still there, but it was relatively, I think it was 1.38 relative risk versus 8 point something for something. And then there's something called an LPIR test, which I'm sure you're familiar with. But can you touch on, because people ask me all the time about my cholesterol is high, and there's some people that say it doesn't matter, and I never say that. I say, look, it's something that it's a flag. We should get more investigation, but we shouldn't ignore that. So let me get your thought on that study, and maybe just the general cholesterol sort of philosophy that you have. I don't know if it's evolved since I last talked to you. I suspect it's fairly similar.
Yeah, well, I'm glad you brought up that study, because I think it is so important, because it seems like there are two debates. Either LDL cholesterol is the most important factor for cardiovascular risk, or LDL cholesterol doesn't matter at all. Right. And those are the two polar opposites. And as is frequently the case, it's, sort of somewhere in the middle. And that women's health study showed, yes, there was definitely a relationship between LDL cholesterol going up and a higher risk of cardiovascular disease in that subset. So this was not a low carb study. These were just free living people, eating however they want to eat without much instruction or guidance. But and I think it was like 1.6. And then, like you said, type 2 diabetes was 10. So that's one of the important things, is like trying to put these into perspective of which is more important, or how much does one contribute? Because if we just focus with our myopic lens on LDL and think that's most important, we're missing the broader picture. And that's what the women's health study, that publication, showed so nicely. And then the LPIR score, which is basically a lipid score, but not looking at just LDL, looking at your remnant cholesterol, your VLDL, your size of your LDL particles, the things that are more associated with metabolic disease. And as that impacts your lipids, that had a factor of 6. So, all of these were on the scale, but type 2 diabetes up here, LPIR here, and LDL down here. So it's not that it doesn't matter. It's just that we need a better context and a better perspective. So I guess the second part of your question is, what is my take on lipids? Well, that is basically my take. This study was great for me because it sort of confirmed my bias and my beliefs that yes, LDL plays a role, but its role within the whole context is actually probably much less than other things such as metabolic health, such as type 2 diabetes, high blood pressure, chronic inflammation. I think addressing those issues makes LDL much less concerning, not zero concern, but much less concerning. And that's reflected in other studies. When you look at those who have, normal HDL, low triglycerides, and high LDL, they're in a much lower risk category than the opposite, with the high LDL and the high triglycerides and the low HDL. Those are two completely different risk categories. So part of the problem is medicine in general, and cardiology and lipidology, doesn't really acknowledge that enough, because the fear is that not enough people are getting statins, that we're missing people who could benefit by cholesterol treatment. That's sort of the mindset of cardiology and lipidology right now. Not the mindset of let's find the people who really are going to benefit most, but the mindset of let's not miss anybody. And in that regard, let's treat as many as possible to lower everybody's LDL. And don't worry about the nuance that it's less important for some than for others. I take the exact opposite approach. So, it's a different perspective. And one is also a very drug-centric approach, and one is a very lifestyle and preventative centric approach, which is the way I think we should be going. And that's certainly what you seem to be doing with your practice and your message as well.
Yeah, Bret, this is one of those things where you have, obviously people that, there's a lot of different risk factors for cardiovascular disease. And, if like I said, when I was an orthopedic surgeon, I had a scalpel, and that's my tool. And when everything looks like a nail, you use your hammer. And, you've seen that sort of theme before. If that's what you know how to do, then that's how you treat everything. And, you're finding that there's much greater nuance in that. As far as, if you look at, you obviously been involved in the low carb scene, the keto scene, there's probably some people doing a carnivore diet that you've seen. Some of those people are still going to be at risk for cardiovascular disease, I would assume. Some of them are still going to develop cardiovascular disease.
Yeah.
Is there a way to sort of say that this person, even despite the fact that maybe their diet is low carb or high fat or medium fat, and I know there's been a shift in the diet doctor realm recently with Andreas talking about, I'm going higher protein, I'll let Ted Naiman. And, I've always been, protein's great. I've been a protein centric guy my whole life, as an athlete. And so, and meat is a good source of protein in my view. But do you find that, how do you, like there's, you've got, one of the problems with low carb is so many people that start at low carb are already sick. I mean, this is what you get. You've got the self-selected sick population. People don't generally take up dietary things for the heck of it. They usually do it because, hey, I'm tired of being tired. And so at baseline, you're starting with people that may already be sick. But how do you differentiate and change maybe the strategy for somebody that comes to you that says, hey, I'm low carb, but hey, my triglycerides are still up there, or whatever. How do you mess with that?
Yeah, that's a great point. Just because you're low carb doesn't mean you've resolved all your issues overnight. It takes time. But I think, one of the most common things I see is someone who kind of gets put on a statin and their lifestyle isn't addressed. And the implication is you're on this for life, right? This is what you need for life. As opposed to, well, let's see what we can do with improving the rest of your risk factors. So I do treat patients with statins or with blood pressure medicine or with glucose lowering medications. But while we're continuing on the journey of improving their lifestyle to address those factors, because it's not that once you have high blood pressure, high blood sugar, high cholesterol, you have it for life. Absolutely not. You can fix those things. You can completely reverse those things with a dedicated lifestyle program, which low carb eating is a big part of. And then might not need medications down the road. So you can use medications as a temporizing effect. I mean, that's what they are. They're a Band-Aid, a temporizing effect as you address the underlying cause, which lifestyles is such an important contributor for. So I think you're absolutely right in the way you sort of phrase that question, that not everybody is perfectly healthy right just because you do low carb. Now you're making improvements and that takes time, but again, you need to evaluate the whole picture. And that's why you don't just get a lipid panel on a fasting blood sugar and call it good. That's why, CGMs are so important. Following hemoglobin A1C is so important. Following inflammatory markers, getting the advanced lipid profile to see your small dense LDL, the size of your LDL, knowing your LP(a), knowing all those other markers and putting them together to say, what is your risk now? How can we improve that risk with your lifestyle? What markers are we going to follow? And then maybe what Band-Aids and temporizing measures we need now to lower your risk, and what will we use as a guideline to wean those down or stop them as we progress. And, we have to be honest that not everybody with a high LDL fits this hyper responder, that Dave Feldman has been so great about promoting and drawing attention to. Not everybody is lean, fit, athletic with high HDL, low triglycerides, normal blood pressure, 0 calcium scores. That's one bucket. Other people can have high calcium scores and still have high blood pressure and still have high triglycerides and high LDL, and they need to be treated very differently. So we do have to sort of assess the whole thing and then use temporizing measures when needed.
Yeah, the idea that you're not going on a medication for life is, I think, very, very, I get almost novel and refreshing to see that, because as you probably in your training, it was just like, people go on this stuff and they may not be on that medication for life, but they're going to go on the next generation, or if they don't tolerate side effects. I mean, they're on a medication, a drug basically for the next 30, 40, 50 years or however long it's going to be. And there's probably, well, obviously tens of millions of people in that situation, and they don't get out of that because they've never been told that, hey, this is maybe temporary, and this is, this type 2 diabetes can be mitigated and handled without medication, if you do the right things.
Yeah, one of my favorite words is de-prescribing, and that's a word I never heard once in medical school, residency, fellowship. De-prescribing. All I heard was prescribing. So de-prescribing, I mean, fortunately, so many docs now in the low carb sphere are talking about it, that this is a phenomenon that we had to learn about on our own and is just so powerful, and patients love it. And it's so empowering, and it's a shame that it hasn't been taught more, but it is my new favorite word and the wave of the future for sure.
Speaking about the wave of the future, I mean, I think, I don't know if, maybe the faith in the medical system is at an all-time low at the moment, perhaps through various reasons. I think, there's a lot of people that are just mistrustful. Do you see a paradigm changing shift going to happen within medicine in general, allopathic medicine? Do you think there's going to be a big shift in the way we do things, or do you think it's still going to be the guys on the fringe, or do you think there's going to be more people moving out there?
Boy, that's such a great question and a hard question to answer. I mean, I absolutely think there needs to be a shift. There has to be a shift, but will there be a shift? I don't know, Sean. I'd like to get your perspective on it, because there's so many vested interests. There's so many, kind of old guard. What's that old saying that like progress happens one death at a time or something like that? Like you need the old guard to sort of start retiring. Let's not say death, but retire and stop practicing and let the new kind of more curious, thinking outside the box, more inventive crews sort of start to take over. I mean, we need to start to see that shift, but I think it's kind of happening at a glacial pace, unfortunately. But it's movement like yours and like Diet Doctor and all the coaches that are popping up and the low carb doctors, and this community is growing. There's no question about it. I wish it would grow so much faster than it is.
Yeah, I mean, the other thing is, obviously, as a physician, you sacrifice many years of, eating ramen noodles and working, 80, 90, 100, 120 hours a week in the effort to have a reward at the end of, but the problem is that reward only comes if you play in the system the way the system is designed, which is, it's diagnose, treat, medicate, rinse and repeat over and over again. And unfortunately, there's some people that are able to do it, but that's not how the system's set up. And so unless you're willing to step outside the system, you're kind of stuck, particularly if you take on $200,000, $300,000 in debt to pay for your medical education, because many people are sitting in that situation. It may take them a decade or more, or 2 decades in some cases, to just get out of debt, depending on their specialty. So yeah, it's kind of like, I kind of liken it almost to the industrial agricultural system, in that, we have these farmers and ranchers that are bought the millions of dollars of tractors and equipment, took out loans, and continually buying the herbicides and pesticides, and
right.
And they're like, they have to, because that's the only way they can pay those loans off, and they have to be in that system that they can get crop insurance. And so it's kind of an analogous situation in my view, and it's kind of interesting. Let me ask you, I'm going to shift gears a little bit. I don't know if you saw this study. You probably have. I imagine you have. There's a recent study came out. It was a physicians or medical healthcare providers survey, COVID-19, plant-based dieters, 70% less COVID outcomes. I don't know if you read that. Have you had a chance to read that study yet? Or
No, I didn't
Okay.
read the study. I read
Okay.
some, people commenting on it,
Yeah.
like the typical, it compared to a standard American diet.
Right,
Okay.
right.
Big surprise. That's pretty much all I needed to see, that
Yeah.
comparing anything to standard American diet in COVID response, like, wow, that's not exactly earth shattering, but okay.
Yeah, I mean, it's the same thing. I mean, it's self-reported data. It's basically, these people that are conscientiously more healthy versus people that don't care. It's basically, you could have said people that eat less sugar, to give up sugar, are going to have probably a very similar outcome. People that conscientiously say, I'm not eating sugar for health reasons, are going to, therefore, it's a typical healthy user bias stuff that we've seen over and over. And it's
Right.
surprising me that we're still seeing that type of data and literature put out there with almost no one even questioning it, or it's making headlines.
Yeah, that's one of the things that just continues to blow my mind, that people promote these nutritional epidemiology studies with no caveats at all about the quality of data, and promote it as if they're, groundbreaking, earth-shattering, conclusive type studies, and with just no caveats of, well, if you look at the baseline characteristics, the people who are eating more plants also smoked less and exercised more and, slept more and took better care of their health in general and saw their doctor more. And the people who didn't smoked more and exercised less and had more hypertension and diabetes at baseline, and maybe were even lower socioeconomic class, or you have these dramatic differences in the baseline characteristics, but yet you promote the science as yet, see, look, the plants did it. It was all because of the plants. And gosh, it's either ignorance or a willful misrepresentation of the data. And, you can, depending on who the individual is, you can kind of pick and choose what you think the reason why they're promoting it is. But it's just bad science. It's certainly bad interpretation of science and bad use of science to support someone's belief system, I think. And look, we're all guilty of that to some degree. If I see an observational study that shows, eating meat is beneficial, I'd be like, see, look. But hopefully I'd also be able to say, now look, it is a nutritional epidemiology study. It's a weak study, but it's the exact opposite of the other evidence that people are using with weak nutritional epidemiology studies. So how strong can the danger really be if we're seeing the exact opposite? So, I mean, we all need it just to be smarter about the role of nutritional epidemiology studies for sure.
Yeah, I mean, I had the opportunity to interview a guy named Gordon Guyatt. I don't know if you're familiar with Gordon Guyatt.
Yeah.
So I mean, he's basically the father of evidence-based medicine. You know, back in 1990, he wrote the single author paper that described the concept of evidence-based medicine. So he's been doing this stuff forever. And grilling him about his stuff, he says, yeah, you know, most nutritional studies don't show anything. I mean, you know, if you look at the strength of the evidence, you know, whether for or against, you can basically say, we don't really know. I mean, I'm fine to say that. We just don't really know. I mean, unless you can do some really, really strong, convincing, I think we've got some stuff on biomarkers, but again, we can debate the value of the biomarkers. You know, we can say, yeah, we go on this diet and our LDL cholesterol goes up or down. You know, maybe that's important, maybe it's not. You know, it's again, it depends on the situation. You know, maybe you know, so I think that's a real quandary that we have, and you know, people don't seem to realize that it's tough to do good nutritional studies. I mean, it's probably even unethical in some ways. You know, it's like, you know, to run a 15, 20-year trial and use heart disease as your endpoint in an actual intervention trial where everything's controlled. And, you know, you would say ideally put people in metabolic wards and control every variable, which no one's going to do. No one's going to sign up for that.
Yeah, and that's the problem. So we either use like mouse data and then assume that what happens to mice happens to us, which is just faulty also. And we use the epidemiology studies, and or we have to use biomarkers and surrogate outcomes. And there, the key is, are we using the right biomarkers and surrogate outcomes? Like, are we using TMAO, which, you know, by itself really has no direct association with cardiovascular risk? Are we using LDL and ignoring HDL and triglycerides? Or are we using like a composite cardiovascular risk? And that's one of the great things about the Verta trials. One of the papers that came out of that was looking at a composite cardiovascular risk, the calculated cardiovascular risk. And it went down by 12%, despite the LDL going up 10%, which just shows that, you know, cardiovascular risk assessment is far more than one biomarker. So we do need studies like that. And yeah, and it's hard. I mean, but we have to recognize it's hard, and we're not going to get the studies we want. So we have to do the best with what we can. And for some, that means just relying on nutritional epidemiology. And for some, it means trying to go beyond that, recognizing how poor that is, and using the best data we have in other realms, plus clinical experience, right? I mean, the other thing that we have to remember is how people feel, how people live, their energy, their excitement for life, their enjoyment of food. Those are important too. Like, those don't show up in mortality data. Those show up in quality of life data. And that's really, really important. And for some, that's going to be more important than mortality data. And that gets lost. I mean, that totally gets lost, especially if your doctor's got 10 or 15 minutes with you. You know, they're not going to have time to get into all that. They're just going to look at your numbers and your prescription. So that's where we have to be our own advocates. Patients have to be their own advocates and say, look, I feel better than I've ever felt. So take that into consideration, because that's worth a lot.
I mean, obviously we're talking a little bit about biomarkers, and there's some more, I guess, when we're looking at disease, you know, there's coronary calcium scans, there's CIMT tests and some other ones looking at pulse waveforms and stuff like that. What do you find, which one of those do you find particularly clinically useful and clinically relevant in your practice?
Yeah, I think, well, calcium scores are great because they have the most data behind them in terms of predicting cardiovascular risk. So they're very helpful, especially if the calcium score is 0. I mean, that's obviously the best that you want, and just really lets you say, okay, look, whatever we're worried about, we don't have to worry about right now. You know, we've got time to sort of figure this out. So that really sort of takes the pressure off, because I see so many people who come to see me and say, look, my LDL is high. My doctor freaked out, said I have to take this statin now. And I say, well, let's start with the calcium score. And if it's 0, we're going to take a deep breath. We're going to exhale and realize that we don't need to panic about this. If it's not 0, it gets a little more complicated because there's no timestamp on a calcium score. So you never know when it was put down. Was it, you know, did it occur during the 20, 30 years of a standard American diet and pre-diabetes, or did it happen in the 6 months since you went on a low-carb diet? You know, it doesn't tell you those answers. But then they can be helpful to follow and trend over time. Things like CIMT are interesting because for a one-time test, they're much less predictive of cardiovascular risk than a calcium score. But where I think they shine is that you can follow them much more frequently, every 3 to 6 months if you want. There's no radiation involved, and they tend to change at a faster pace, both progression and regression, than calcium scores, whereas calcium scores usually only go one direction. We've heard there are some examples of regression, but the overall vast majority of calcium scores either stay the same or progress and don't regress, whereas CIMT can do both. So that's where CIMT, I think, can be helpful to follow over time. But, like I said, the data isn't quite as strong as it is for a calcium score. Other tests like endothelial function can be helpful. They're a little bit harder to get. They're not as ubiquitous to find. But I think those can be helpful too, helpful markers. So yeah, there are other emerging tests, but those are generally sort of the top 3 I see people talk about and want to get that I think are helpful.
Just to just kind of follow, because I had a coronary calcium test a little while ago and it was 0. It's cool. But of course the criticism always is, well, you're missing soft plaque and you need to get cathed or something. I'm like, why am I going to get cathed? I'm not going to go get cathed as an asymptomatic guy. It's crazy. But I mean, if you have a 0, the likelihood of you having soft plaque is much lower than if you had a 20 or 100. Is that a fair assessment? And
Absolutely. Absolutely. Is it true there are rare cases of missing significant soft plaque? Yes, that is true, but they are rare. And I mean, the data is clear. Your risk of having a cardiovascular event over the next 10 years with a 0 score is very low. Now, you can do a coronary CT angiogram that's non-invasive, that can show soft plaque, has a higher radiation dose than a calcium score, but still, as long as you're getting it at a reputable place, the radiation dose has come down quite a bit and is still reasonable. I wouldn't be opposed to someone getting a CT angiogram every 10 years or something like that if they wanted to follow that. But the number of people that is going to show something in with a 0 calcium score is extremely low. So I'm not sure if it's worth the money or the time to get it done for a lot of people.
Yeah, I just want to entertain. I got a couple of questions coming in, Brett, if you don't mind. Somebody's asking, does LDL cholesterol correlate with soft plaque? Is there a linear correlation with those 2 markers?
Does it correlate with soft plaque? That's a great question. Off the top of my head, I can't think of a study that says LDL definitely correlates with soft plaque. Now, I know it doesn't tend to correlate with calcium score in a number of studies. So my assumption would be it also doesn't correlate with soft plaque, but I gotta be honest, I can't think of a study off of the top of my head. I would have to do a little more research on that. Yeah.
Yeah, maybe there's there might be data on that. There's another one. There's somebody saying, I've been on a low carb ketogenic carnivore diet for a year and a half, and my insulin is extremely low. It's like 1, fasting insulin of 1, very low, but my triglycerides went up, from 75 to 200. Is that consistent with fatty liver? Is there some dynamic nature to triglycerides? I know it's, what did you eat last?
Right.
Coffee has an impact. What are your thoughts on that sort of situation?
Yeah, triglycerides are definitely interesting. I mean, you want to make sure that it is a true fasted blood test with nothing but water the morning of the test, and at least an 8-hour, preferably like a 12-hour fast. And if that's the case and your triglycerides do go up, I mean, there are some people whose triglycerides go up. Now, you have to put that again into context, right? If your blood sugar and your insulin have improved, if your overall metabolic health has improved, if you're losing weight and your blood pressure is going down, then maybe triglycerides going up is kind of worth the trade-off. And you can do other things, whether it's fish oil or even some prescription medications or something to address it. Or you can try and address the fatty nature of the meat you're eating. Maybe go to leaner cuts and more monounsaturated fats. It's not the most popular advice, but if you're looking for ways to see if that will affect your triglycerides, I think that's a reasonable experiment. And again, when we talk about results from trials or results from dietary interventions, we usually talk about the average, right? There's the bell curve. and we're talking about that average. And there are people on both ends of that bell curve that are going to have other responses, and triglycerides can be one of those. So there's no question the vast majority of the people who go carnivore or go low carb see their triglycerides plummet, but there's some who are going to see it go up. And so that sometimes you have to do different experiments to see how you react to that. But again, it's what else is happening. If that's the negative, what are the positives and what are the trade-offs? Now, if your triglycerides are 1,000, that's a different story. You know, there are genetic inborn metabolism defects and things of like lipoprotein lipase gene mutations where your body just can't handle the fat, and you need to go on a low-fat diet if you have lipoprotein lipase deficiency. So that some people might have to do that, but if you don't have those inborn genetic defects, then chances are higher fat, lower carb is going to be better for fasting triglycerides.
Yeah, just to nerd out a little bit, and it's probably something you may not know. I looked at this study. I read all kinds of crazy studies on all kinds of stuff, and I was looking at this study on marbling in meat, and depending upon where the fat is in the beef, if it's intramuscular marbling, it tends to be higher in monounsaturated fat as opposed to that. Like you get a ribeye with that isolated piece of fat on the side, that tends to predominantly be slightly more saturated fat. And then there's certain breeds of cattle like Wagyu, which tend to have high levels of monounsaturated fat, highly marbled. And so if you're saying you want to make a shift, you know, if you can afford it, go eat Wagyu beef, get the high end or get the really marbled prime stuff, and you may see a shift towards a monounsaturated profile. And, you know, I think, and that's another thing most people understand. Beef is very rich in monounsaturated fat. The predominant fat in beef is monounsaturated, closely followed by saturated fat. They're like 46 and 43%, and then polyunsaturated is like 7% or something like that.
Yeah, that's a great point, because beef is always thought of as a saturated fat, but it's as much mono as it is saturated. And I think I remember reading something that grass-fed and grass-finished also has a higher monounsaturated and a little bit lower saturated compared to the grain-fed. But I would need to sort of revisit that.
I think it's actually the opposite, quite honestly.
Oh, is it?
Yeah,
okay.
There's a study Texas A&M did that, looking at grass-fed versus grain-finished, and actually grain-finished had a slightly higher monounsaturated fat. It's not much. It's you know, it's a few percentage. You know, it's clinical significance. Who knows? And that's the other thing. You know, this is a point that Siobhan Huggins maybe just kind of keyed me into, and I kind of thought about this, but you know, we're talking about blood glucose control, right? And you know, obviously, you know, we all want good blood glucose. We want low blood glucose. We want stable blood glucose. That's the mantra. You know, and I think there's you know, when I exercise really, really hard, my blood glucose goes up. It's supposed to. I mean, there's times when it's supposed to go up and down, just like insulin's supposed to go up and down. And so we kind of get, you know, again, this sort of really focused view on one biomarker, and we always want to keep it to be zero. And the answer is not zero. It almost never is. There's always some variation in there. But the thing about, you know, what she pointed out, says, you know, you can, you know, alcohol has been shown in some cases to lower blood glucose, right?
Right.
And so we're like, oh, great, my blood glucose is lower, but what does it cost? I mean, you're basically probably damaging your liver to prevent endogenous glucose production. You know, I mean, what is the method by which, you know, the means doesn't always justify the ends, is what I guess I'm trying to say. And so we can look at things like, you know, metformin, you know, used to be this, you know, was this wonder drug for longevity, and people saw, wait a minute, it seems to be like a mitochondrial poison. You know, we're seeing that. And so I kind of come back to, like, you know, is the biomarker outcome that you want necessarily the goal? Because like you said, there may be a trade-off. Maybe your triglycerides went up, but it's for a good reason relative to the other things.
Yeah, the question of why is it going up is equally as important as if it's going up. And like you said, I mean, I love when I wear a CGM and my highest glucose of the day is for my bike rides, you know, and that's the way it should be. But it doesn't mean it's like, oh God, I hurt myself by going on that bike ride because my blood sugar went up. No, because it goes up when you exercise and comes right back down, which does exactly what it's supposed to do and shows insulin sensitivity. The problem is when you have your first meal and it goes up and it stays up and it stays up and it stays up and then it kind of slowly goes back down. Those are two completely different paradigms than if it goes up and down like that, right? And the same thing for food, though. You know, if you think just, you know, chugging fat all day, drinking bulletproof coffee and eating sticks of butter all day is the best way to go for your blood sugar, which it may be, but you're going to be protein deficient, you're going to be nutrient deficient, right? So there are other reasons to eat other than keeping your blood sugar low. So you want to make sure you're getting adequate nutrition, getting adequate protein, and still not adversely affecting your blood sugar. So we know average blood sugar is very important, average blood sugar for the entire day. And we know glycemic variation is important. So it's sort of the combination of those. Now, if your blood sugar goes up, you want to make sure it comes down within an hour, at most 2 hours, and that its peak is, 120, maybe 140, but not the peak of 200 and back down. You don't need necessarily a flat line all day. Little variations are okay, as long as the reason they go up is acceptable and it demonstrates insulin sensitivity, that they're coming right back down. So yeah, we need to be a little bit more nuanced as well about our blood sugar variations.
Yeah, that's one thing I've seen, like endogenous glucose production during intense exercise can go up 1,500%. I mean, it just your liver can make a lot of glucose very quickly if it needs to, and it makes sense from a evolutionary survival standpoint. If you need to run from a bear, you better have the fuel to do the exercise. And that's the other misconception. With an athlete, they say, well, if you're not eating carbs, you can't perform at high intensity. I'm like, I do it every single day. My body gives me the fuel I need. It's smart about that. We're kind of designed for that.
Yeah, you're the prime example for that. I mean, the weights you lift and the performance on the rower that you do with zero carbs. I mean, I don't know how anybody can argue against that, because it's very impressive.
Well, and it's I'm not unique as an individual. I've got lots of now world-class athletes doing it. Professional fighters and professional football. We got a guy in the NFL went to the Super Bowl, won a Super Bowl, doing a full carnivore diet. So I mean, it's pretty interesting stuff, and I think there are some of these other benefits. Let me ask you about this, because this is a point I want to make. I think you made this very good point. The fat. Louis Newberg back in the 1920s. You may have seen some of his data. He was. This is before insulin. This is right before insulin was invented. Insulin came out in 25 or 26% of the year, but early 1920s, they were getting all these really horrible septic, basically end of life diabetics. And they put them on a high-fat diet. They put them on a 90% diet, which is very, very low in protein. We're talking 30, 40 grams of protein a day. And they reliably got them to stop stop urinating glucose. I mean, that's what they could test back then. They didn't have, fancy monitors. So they could test for glucose in the urine. They brought them down. And they actually, these people got better. They got healthier, and they actually could sustain for several years on that very high-fat diet. But again, the problem was, and what I see, because we have people in this community that will eat a very high fat diet, and they'll roll in there with blood glucose 40, 50, and they're not hypoglycemic. They're just chilling out. They're just kind of like, I'm fine. An endocrinologist might see that number and go, oh my God, give them a stat dextrose, infusion. But Cahill has shown, he had people that he put on, basically fasting for prolonged period of times, and then dropped insulin in them and watched them sit there with a blood glucose of 15 and be conversant. So we know that there's this sort of maybe protective effect of maybe a high-fat diet in that situation, perhaps, or ketones or whatever it is. But at the same time, what I see is, if you're eating enough protein or enough carbohydrates, that fat is going to just, that area under the curve is going to be smeared. It's going to, you're going to calculate fat is going to have an impact on glycemia, and it may not go as high, but it's going to go slightly higher, but for much longer, perhaps. And this is why there's something called a Warsaw formula for calculating protein and fat, which most people, if you go to endocrinologists, they're going to count carbs, and if you're type 1, count carbs, or even a type 2 and slam in some insulin based on that. But we are seeing that fat is, in some situations, particularly as, the early days of keto, as you probably remember, it was people, gorging on sticks of butter and, throwing all this MCT oil in their coffee. Is that something you guys are largely getting away from for the most part?
Yeah, it's interesting. We can't deny the fact that some people see tremendous success with that type of eating. Like, that's undeniable. And so I would never, me personally, and diet doctor in general, would never say you should not eat this way. But we also wouldn't say this is the way to eat low carb and the way to eat keto, right? That 90% fat or even 80% fat. Like, for some people that works great, especially if you're addressing a neurologic condition, or whether it's a mood disorder, or Alzheimer's disease, or traumatic brain injury or something. The brain seems to really like ketones and really like higher fat. So in those situations, maybe that's better. For general health, weight loss, blood sugar control, metabolic health, blood pressure control, I don't think that's the best approach long term. Although when you're starting off, maybe it is a good approach because you're giving up so much, and you need to, you need to get enough energy from other places. So fat is that energy source. But then I think it's pretty clear that a lot of people tend to progress and then stall before they've hit their goals. And I think that's a very good time to reassess and shift and lower the fat and raise the protein. And the literature is just full of studies showing higher protein diets are more satiating. What I mean by that is eating fewer calories the rest of the day. Now, for a lot of people, fat can be satiating as well, but at what balance? So that's where I think raising the protein, lowering the fat, and keeping the carbs low. And when I say lowering the fat, I mean 60% of your calories from fat. That's by no means a low-fat diet, but very different from 80 or 85% of your calories from fat. That's going to be the sweet spot for a lot of people. That sort of 25-30% protein and 60% fat, or that's going to be a sweet spot for a lot of people to overcome stalls, to find a long-term sustainable approach that's going to help their metabolic health and still be enjoyable and help them feel good and give them enough energy. So yeah, there definitely has to be a balance there. And what's interesting when you look at all these randomized trials, there are some 30 some randomized trials of low carb diets that are true low carb diets, not the 40% calories low carb, but the true low carb diets compared to some control or low fat diet. Not only did the low carb diet lower carbs, but they also raised protein in the vast majority of those trials. So a lot of the literature we point to say, see, look how good low carb is really look how good low carb and higher protein is. So we don't have a lot of studies looking at the 80%, 90% fat type diets compared to controlled diets to show metabolic health benefits. Those are much more rare. So yeah, I think it's sort of a long-winded answer of a way of saying I think the combination of lower carbs, higher protein for most people is where they're going to see the best benefit. But I would never deny someone who says, look, I'm having a couple bulletproof coffees a day and eating 80% fat diet, and I'm doing great and hitting all my health markers. I say more power to you. Go for it. Keep going. But just keep monitoring things, right? You always have to monitor for continued success.
Yeah, and that's kind of the observation that I've seen within this community. I've had the fortune to interact with thousands and thousands of people. I do that day after day after day, and so I see something very similar. It's interesting that 60% fat, 65% fat diet is, it's almost kind of like a T-bone to ribeye steak-ish. I mean, if I look at the macros on that, that's about where that is, which is, kind of what my diet often is. And I think I'm pretty happy in that regard. But I do find for me personally, and I think many people in this community find the same thing, going to a little bit of a leaner ship generally results in better body composition, helps to break stalls. I mean, I find that, I do often recommend something where we cycle fat in periodically particularly if you go fairly lean, and that seems to work quite well. There's I'll give you another nerd study here. There's a dog study that looked at dogs self-selecting their food. Now you have to remember they're not humans and they've got smaller brains. They don't require the energy, but what they do is when they are initially approached with a diet, particularly if they've been hungry for a while, they'll select high fat, relatively high fat. But as time goes by, 2 or 3 weeks go by, then they will automatically start to veer towards a leaner diet. So there may be some sort of fat soluble vitamin deficiency that they're trying to meet, or energy balance issue. And then once they've achieved that, then they sort of maintain it at a leaner level. And I think we may see something analogous to that in the human population, or at least the ones that are really truly saying, okay, I want to really, and again, your goal may not to be able to walk around with a six-pack as a guy or whatever, but I mean, if you are, more often than not, that's what gets you there, at least in my experience.
Yeah, and I think that's something similar for hibernating bears too. That there's this concept that the way you eat now is the way you should always be eating. And if you look at the animal world, that they cycle. They definitely cycle through their protein percentage, fat percentage, and carbs. Same with hunter-gatherers based on what's available. So we don't live in that environment. We have a constant supply of food, at least most of us do. So we can pick and choose. So we tend to eat in more of a standard method. One, because it's easier. You don't have to think about it as much. It's logistically easier. You get in a pattern. But you got to wonder, maybe there's something to a little bit of the cyclical nature of eating. That's what the animal kingdom seems to suggest.
Let me, this is probably a topic that I'm sure a lot of people are interested in. Differences between men and women with regard to cardiovascular disease and diet and weight loss. And we always have the menopause, the poor menopausal women. They're always like, oh, no one helps me. I'm always, because they've got it harder. I mean, they've gotten this huge shift in hormones, and they often put on weight, and as hard as they try, they can't get it off. But do you find a difference either with regard to cardiovascular outcomes? I know there's differences. Obviously, women are suffering from these non-STEMI MIs more than men, and so on and so forth. So can you talk about the dichotomy between males and females and as regard to health and diet goes?
Yeah, one of the interesting things is just the perception of cardiovascular risk for men and women, that it's sort of perceived to be much lower for women in general than it is for men. That, like breast cancer is the biggest concern for women. Well, statistically, heart disease is still the biggest killer for women. But breast cancer is sort of more emotional and more women centric, so it gets more attention for women. But really, if you're talking about statistics, you got to focus on heart disease. So it's still the biggest risk factor. It tends to peak later in life for women than for men. Now, how does diet factor into that? I mean, that's a great question. And I'm not sure there's necessarily a major difference in terms of dietary contribution to risk, because it's still going to affect blood sugar, insulin, lipids, blood pressure, weight control, metabolic health. Diet's going to affect men and women fairly similarly. Other than, as you mentioned, post-menopause, women see a drastic change in their sort of response to nutrition and the calories and lifestyle, whereas men don't see quite that drastic change. Their testosterone can get lower over time, but it's not sort of like a fall off a cliff, in the course of a couple of weeks or months, like it can be sometimes for women. So that's the biggest difference. And actually, interestingly, when you talk about low-carb diets, Professor Lucia Aronica at Stanford did an analysis of the Diet Fit study and found that compliance for women was much lower than compliance for men on low-carb recommendations. And part of that is just the stereotype, right? When you think of someone sitting down and eating a salad, you think probably of women doing it. When you think of someone sitting down and eating a steak, you think of Shawn with his big machete knife cutting the steak to eat, right? And there's a stereotype that it's one or the other. And so some women are going to have a harder time sitting down and ordering that big steak, even though there's no reason for it to be any different other than a cultural stereotype. So I think that's probably the biggest difference between men and women when it comes to diet, is just getting over that cultural stereotype hurdle, that it's okay for women to be carnivores. It's okay for women to eat a lot of meat. Perfectly fine. You're probably going to help your health. And there's absolutely nothing wrong with it, but people might look at you a little sideways. Yeah.
One of the other, this is one of the things that I think is we have a lot of room to make a lot of gains in is, we traditionally see, well, if you just lose 10% of your body weight, all your health problems are going to get better, right? I mean, it's just, everything that gets better with health is because of weight loss. And yet I see people that are underweight, in particular like rheumatoid arthritis and people with autoimmune disease and Crohn's disease and all that stuff. They're getting better by dietary shifts too. They're not losing weight. In fact, sometimes they're gaining weight. And so we've got this sort of mentality that it's all about weight loss. And I have people tell me that. And I say, no, it's not. I see people all the time that are skinny and they're unhealthy. And so are you seeing that within your community as well, Bret?
Yeah, you mentioned body composition earlier. I mean, that's so important. And, instead of talking about weight, we really should be talking about body composition, because if you lose 10% of your weight, but it's the majority of it is lean muscle mass, you're helping some things and you're definitely hurting other things as well. So you definitely want to talk more about body composition. And so, yeah, especially like, Southeast Asians or people from India, or, traditionally they're going to be skinny, but still can be very metabolically unhealthy. And you actually do need to help them gain weight in terms of muscle mass and lose some of their visceral adiposity to improve their health. And it's not just all about weight loss. It's about redistributing the weight. And that's where body composition measurements, I think, are so important and so valuable. And where things like resistance training and protein really rise to the top in terms of the benefits they can have. And some people say, if as long as you're getting 18 to 20% of your calories from protein, that's adequate. That's all you need. Well, again, it depends on what are your goals, right? If you are one of these skinny fat people, someone who needs to build muscle and lose visceral fat, you're probably going to see much more benefit at that 30% protein range than at that 15 or 20% range. So, you have to factor in your goals there. So yeah, I do see that a lot. And that's where I think body composition measurements can be so helpful.
Yeah, that's one of those things that I think if physicians were being held accountable for your patient's weight to height ratio more so than statin utilization and LDL cholesterol over 190, I think we'd have a very different conversation and a different focus. I mean, it's something simple that doesn't cost anything. A tape measure gets you there, and so it's kind of one of those things where we don't focus on that. I mean, I constantly get people telling me, well, just because you're lean and have muscle doesn't mean anything. That doesn't mean you're healthy. And I'm saying, yeah, it kind of does. I mean, there's a lot of data that supports that. It doesn't guarantee it, but I mean, it certainly compared to the average 55-year-old with a big old beer belly that's laying on the couch, I would put my odds up against that guy just about any day of the week. But I mean, it's kind of this type of thing.
Yeah, and that's where these studies, like these population-based studies looking at body mass index, right? If you use body mass index over hundreds of thousands of people, okay, it can be a helpful determinant. But when you use it for one person sitting in front of you, body mass index can be fairly worthless. And that's where you do need a much better measurement, which, like you're saying, could be a tape measure. Just measure your waist, measure your height. You want to be below 0.5. Doesn't get much easier than that.
Yeah, and I can't remember ever going to a doctor where that was done. I mean, maybe when I was a baby, when they measured out crown to rump length or something like that, but they just don't seem to do that anymore. It's kind of interesting. What do you see anything coming up on the horizon, or any new things or new trends or technology? I know the CGM, this is my one concern about a CGM is, people will, like we talked about, there's supposed to be a little bit of variability, and they'll sort of, maybe they won't exercise because they're afraid that their blood glucose is going to go. Well, I'm not going to do that hard exercise. I'm not going to go do that set of deadlifts because my blood glucose is going to go to 150 or 140 or whatever it might be. But this is the other thing that I really find it. Information is helpful, but it doesn't always result in a behavioral change. I mean, how long have calorie labels been on backs of packages? I mean, that's been there for, I guess, in the 1970s, maybe. I don't know. And still people eat more than they probably need. I think this is another misconception. I'm sure you probably share my view on this, but I get accused for being a zealot and saying that calories don't matter. And I've never really said that. I said, look, they matter, but there's food quality also matters, and so on and so forth. There's people that tell me you can eat unlimited amounts of fat and you never gain weight. I'm saying, no, that's not the actual. What is your thought on the relevance of calories in the whole scheme? Is it, some people say if you think it's the only thing, you're wrong. And if you think it doesn't matter, you're wrong. I assume you're in that camp of.
Yeah, there's no question. If you want to lose weight, you should be at an overall calorie deficit. Now, does that mean you have to count calories? No, absolutely not. Now, what it means is you should find a way that you eat that you can naturally reduce your calories without thinking about it, right? It's this idea that you have to count your calories, you have to white knuckle it and deal with your hunger, and just, you're just not strong enough if you can't do that. Well, that's just such a faulty misconception. But instead, if you find a way that you can eat where you feel satisfied, you enjoy your meals, you're naturally full, and you naturally reduce what you eat, that's the sweet spot right there. And that's what studies show for higher protein, lower carb interventions. And that's what I think, we all see with our clients, with our patients, and with ourselves, that eating that way really does help reduce calories. So that's where I think the goal is, addressing hunger, addressing cravings, and addressing proper nutrition and enjoyment in your meals. And if you can find a way to do that, that's fantastic. And I think it's pretty hard to do that when you're eating a much higher carb. Not that it can't be done, but it's much harder to do when you're eating a higher carb diet, no question about it. And that's where food quality, like you just said, comes into play. Are you getting your protein from a protein shake, which is, not the end of the world if you need to add more protein, but it doesn't come with a lot of other nutrients? Or are you getting your protein from steak, which comes with a lot of extra nutrients, right? So that there's a difference there in terms of your body meeting its needs. So food quality definitely comes into play.
Do you see any consistent, we hear about, some people just can't do a low carb diet, where they have to have carbs. And again, I want to, I think it's important to point out, like, certainly Kevin Hall's study looking at ultra processed foods. I mean, we'll say carbohydrates, but I think what we often mean is, the junk food carbohydrates, the cookies, the cakes, the pizzas, the ice creams, and so on and so forth, which, I mean, no one's out there, scooping Domino's sugar into their mouth. I mean, we just don't see that. I mean, if they do that, that's pretty bizarre. But so we have this, but I mean, and certainly there are studies that show that carbohydrates tend to drive appetite more than other things. I think that's fair to say. And again, it may be nuanced on what the carbohydrates are, but do you see that there's any consistent population? I've heard this, women can't do low carbs. They have to have carbs during their menstrual cycle. Or have you found anything that's really, truly evidence-based that would point to a population that just absolutely cannot do a low carbohydrate diet? I know there's people that say they can't, but I mean, is there any?
Yeah, I mean,
evidence?
aside from, again, rare inborn metabolism defects, genetic defects where you can't metabolize fat, very, very rare, which you would know, like as a kid, you would know if you have that or not. Aside from that, really not. I mean, it's true that some people may feel better adding carbs at certain times of the month for women, or during, depending on certain exercise routines. But none of that is really evidence-based. That is mostly anecdotal and can be overcome with different protocols, with changing your diet in different ways, with changing the timing or intensity of your exercise, or, those things can be overcome. But it's also not the end of the world if you do have to add carbs, if you have to carb cycle here and there, as long as, again, you're cycling with the right types of carbs and you're not finding that your cravings spike and you start binging when you increase your carbs. But if there are plenty of athletes who carb cycle and can do very well with it. There are people who do seasonal carb cycling and can do very well with it. But and actually I wrote a guide at Diet Doctor about carb cycling, but there are lots of caveats, right? You have to make sure you're not one of those people who carbs set you off the edge. And because, there was this great study by David Ludwig and some of his colleagues showing that higher carb meals stimulate your reward center in your brains more with these functional MRIs. And just because it does that doesn't mean you're going to overeat and crave more, but some people clearly do. And, again, if your carbs are, above ground vegetables and some low sugar berries, maybe some legumes to a limited degree, and you do that purposefully, all right, a lot of people are going to do just fine with that. But you just have to know where you fall on the spectrum, because some people are going to slip up and it's a slippery slope.
Yeah, that slippery slope thing. And like I said, I have people in here that, will do that. They'll add some fruit. I'm like, that's great. If it works for you, it works for you. I'm not going to make a blanket recommendation that everybody should do that, because you do find those people that, you tell them to go eat some berries, and then 3 months later they went on a 3-month bender of, ice cream and cookies and cake, and they can't deal with it. Food addiction is I think there's some real issues with that. Do you guys have any mechanism by which to, I mean, we have this, the support network and coaches and meetings all day long in here to deal with that, because we do have these people that have really true addiction issues, and that helps. Does the Diet Doctor address that in any particular way?
Yeah, well, we've had a whole series of guides and Q&As with Bitten Johnson, who is a sort of a food addiction expert. So we definitely have had a lot of her material on our site. And we're certainly constantly trying to develop new materials and guides and information to help people along these ways. And this is a very important issue that we definitely need to talk about more. I recently did a podcast with Michael Moss, who wrote a book about processed food addiction that will be released sometime in the next couple of weeks, I think. So I mean, it's an issue that needs to be addressed, and frequently does require, group coaching or one-on-one coaching, which is great that you offer that and can help so many people with that. I mean, that's another very important aspect. Information is great, knowledge is great, but sometimes you need a little extra help and a little extra support to get through it, especially when you're dealing with something like an addiction. And addiction is a sort of a dirty word, and it's a hard word to use sometimes. People will push back. Well, is it really an addiction? And look, are you talking about legal addiction, or are you talking about what the people feel and how they react? And that's what I care about. I mean, legal is important if you're talking about policy changes, but for individuals, there's no question people show very addictive tendencies to food, to sugar, to carbs, and that needs to be addressed. Yeah, absolutely.
Yeah, I'm just interested, because you interviewed Michael Moss, and I saw some little bit of previews on what he's talking about. And I just wonder, I mean, is the food industry actively trying to kill us, do you think? I mean, what is your thought
No,
on
the
that?
food industry is actively trying to make as much money as humanly possible. That's it. That's all they're trying to do. They're not trying to help us. They're not trying to hurt us. They're just trying to make money. And unfortunately, the way they make money is by hurting us. That's just an outcome because the way they stimulate our reward centers is with sugar, fat, and salt and no other nutrients. That combination with no other nutrients and high calories. So we just want to keep eating that stuff. And it's not going to do them any good to make a product where you eat one and feel full and don't want any more. That doesn't help their bottom line. So it is really interesting. Like we could say they're evil. The processed food industry is evil, or we can say they are brilliant business people, brilliant marketers, and they're doing a fantastic job at their job. Unfortunately, their job is pretty bad for us.
Yeah, I think it's primarily financial motivation. I mean, why not? I mean, they're in business. Every business wants to make a profit, and they're going to do what makes they did not sign any contract with the American people or anything. They say we're going to provide you food that's going to make you as healthy as possible. It's like we're going to give you stuff that's cheap and tastes good. It's up to you to kind of go from there. And so anyway, well,
Yeah,
Bret, go
yeah.
ahead.
Well, I was going to say what some of the things Michael Moss talked about was, some of their arguments is, well, people know, what's good and bad for them. They can choose what to eat. It's not our fault as food manufacturers. We just put it out there and people choose what to eat. Like that's sort of their defense. And well, not everybody can choose as easily as others. So yeah, that's important.
Yeah, I mean, particularly we see it in the impoverished populations. I mean, they almost don't have a choice. I mean, I say you could go to McDonald's and get a hamburger patty and get pretty healthy food. It's usually available, and if you throw away the French fries and don't drink the Coke and stuff like that, you can do it at least a lot better that way. Brett, what's up on the horizon for you? Do you have any things coming up? Any changes that you're looking forward to the next year or two?
Yeah, yeah. I mean, you sort of mentioned briefly like what I think the future is, and this concept of all these different wearables and all this different data that we can track, but it seems like so fragmented. You get your blood sugar here, you get your scale here, you get your labs here, and your blood pressure. It seems to all be fragmented and difficult to sort of assimilate all together. And one of the things that we're trying to work on is a way to bring all that together and integrate it with your food choices and have meal plans and recipes and shopping lists to make your life easier, and then find a way to sort of coordinate it with all these results and track your progress so that you really can find the personalized dietary approach for you. Is it carnivore? Is it keto, strict keto, 20 grams of carbs? Is it more moderate low carb? Is it higher protein? We can have guidelines to help you decide which one might be better for you. But what's even cooler is to be able to track everything and really help you optimize what you want to optimize, right? Not what some doctor or some governing board thinks you should optimize, but what you want to optimize, whether it's how you feel or how many headaches you have, or what your belt size is, or how energetic you are, or what your LDL is, or what your blood sugar is, to help you optimize those things with the diet that's best for you. So developing this program that's going to work in that way, that's what I'm most excited about. And we're really starting to make some ground with that at Diet Doctor. And also to help reach out to coaches and help coaches and doctors and nutritionists and personal trainers to help them as much as possible. We're building a new feature called the DD Pro feature, the Diet Doctor Professional feature, to help you help your clients, basically, to give you the resources you need, so you don't have to come up with all the recipes and meal plans and shopping lists, and but we can provide that for you and provide you a platform where you can interact with your clients to really help them. So those are sort of two of the most exciting things we're doing at Diet Doctor that are to be coming down the pike in the next 6 months, year, 2 years, something like that, and keep building upon it. Just to find better ways to help everybody get healthier, because if you're not going to get it at your doctor's office, you got to get it somewhere else. And we would love to be that place for people to get healthier.
Well, I certainly wish you guys a lot of success with that. I think we need, there's a huge need for that. I mean, there's literally hundreds and probably billions of people that eventually, through your community and others, that will hopefully address this. And so hopefully we can go forward. And reverse what we've seen, you know, because I just, you know, we've just seen a trend of every year it gets worse and worse and worse without turning this Titanic, you know, ship crash around. You know, we've got the ice, you know, I don't know. It's like, can it get much worse? I mean, what percentage of the population has to be obese before you know, it's become the majority now, unfortunately. You think about it. I mean, what is it? Something like 72% of Americans are classified as overweight. So it's just kind of crazy. But anyway, thank you, Bret. Let folks know where they can find you if somebody's interested in being a patient of yours, how to find you on your social media, diet doctor, so on and so forth.
Yeah, the best site for most of my work now is at dietdoctor.com. It's where I write guides and I edit and medically review the guides. And we have so much great information at Diet Doctor to help people out. On Twitter, at BScherMD on Twitter. And then be a patient of mine as long as you're in one of the states where I have a license, lowcarbcardiologist.com. I'm licensed in California, Nevada, Arizona, Utah, Colorado, Texas, Illinois, and Ohio. So if you're in one of those states, I can help you out. That's at lowcarbcardiologist.com. Oh, you're muted there.
Yeah. Thanks for your time, Bret. Appreciate it.
Yeah.
Have a great, wonderful day. It's beautiful outside here. I'm sure it's nice in San Diego today. And hopefully you'll get outside and be able to enjoy the sunshine a little bit for you.
Get out on my bike later today. Thanks for having me. It's always a pleasure to talk to you, Shawn. Thanks.
All right, folks. We'll see you guys tomorrow, or otherwise have a good weekend if I don't see you. Take care, everybody. Bye-bye now. See ya.